Welcome to the NWA ETC Project Echo. I'm Kent Unruh. I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, it's a pleasure to introduce Paula Cox, who many of you know from Hep C Echo. Paula is a nurse practitioner here in the liver clinic and part of the expert panel for Project Echo Hep C, and I will turn it over to Paula.
Thank you, Brian. Today I'm going to talk a little bit about a topic I think that appeals to a lot of us, or at least a lot of us have had some experience with, and it's in when we caring for chronically ill patients and talking a little bit about compassion fatigue and burnout. So when I preparing for this on the literature search, looking under the terms for burnout, there were a lot of terms that I found that were related, things such as wounded healers or compassion fatigue, secondary traumatic stress disorder, all of which were kind of coupled under the burnout topic. Interestingly, though, they're all a little bit different. This term that's been coined, burnout, by the literature that we have today, dates back to about 1960, primarily in the psychology literature. But in fact, this whole notion of burnout and compassion fatigue goes way back to actually Greek mythology. So the way I understand the story is the god Kronos, who was actually married to Rhea, was having an affair with this lovely little sea nymph. And in order to, his wife was finding out about this affair, so in order to kind of cover his trail, he turned himself into a stallion so that she wouldn't recognize him. Unfortunately, the sea nymph, her name was Philra, ended up getting pregnant, except for when she gave birth, their child was born a centaur, and his name was Chiron. So both Kronos and Philra were kind of mortified over this whole thing. So they abandoned Chiron, and later on he was adopted, I guess, or sort of raised by people up on Mount Olympus. But he became known as a very gentle centaur. Centaurs in that day were they were sort of the drunks, the obnoxious. They'd come in, kind of burn up these villages and were very rowdy. He, however, was very kind and sort of dabbled in medicine. He did a lot of herbal medicine. He taught Achilles how to use plants for healing, and had a great reputation. Unfortunately, what happened is there was a beer brawl going on between the centaurs in the village where he lived, and Hercules was part of this brawl. And he ended up shooting one of the centaurs with his poisonous arrow. And so this centaur came to Chiron to be healed. But during the process, Chiron stuck himself with this poison arrow. And then, unfortunately, because he was born from a god, he too was immortal and lived for a very long time with pain and discomfort. And finally, over time, figuring out that if he could, the way to become mortal was to give your life for someone else. And so Prometheus got to live, and Chiron finally got to end his agony. So he has sort of contributed with this whole notion of what we call wounded healers, people that are injured themselves but are able to give back and help others. The next topic that was coined, and this one goes back not quite as far, this was probably in the early 70s, is this notion called compassion fatigue. So as healthcare providers, we learn to be very objective and analytic in our professional role. We sort of put personal feelings aside and objectively evaluate and treat our patients so that we can do what's best for them. On the other side, it's really, because we're human, it's really hard not to be compassionate and empathic with our patient. This helps us, I think, be more, provide better service and deliver best care. But unfortunately, because of this ability that we have to, have a lot of compassion and empathy for our patients, sometimes it can become overwhelming. And so that's kind of what compassion fatigue addresses. It's the stress is more of a response to your patients. It's those feelings sometimes that we get dealing with chronically ill patients of helplessness, frustrations. Maybe your patients aren't getting better. Maybe you're not able to do anything more for them, and they continue to decline. It's all of those feelings, and when they become escalated and overpowering, we call that compassion fatigue. Generally, it's gradual. And it occurs from helping or wanting to help others, not so much from the job itself. So the symptoms of compassion fatigue are very similar to those of PTSD. There's sort of this hyperarousal state where you may sort of be obsessed. You think about what you could do differently. Maybe you're irritated because you're very frustrated that you can't do more. There's a lot of hypervigilance, kind of going over, did I do everything I could have done? Is there anything else? There's the avoidance of, when the patient comes into the clinic, those feelings of, oh gosh, here we go again. I don't want to go in there. I don't want to talk about this. Or because it's painful for you to keep bringing this up and feeling like your hands are tied, like you don't know what else to do. And then there's that re-experiencing. Sometimes you think about it. Maybe you have a dream about it. Maybe there's just some reminder or something. These are all these symptoms that we get of compassion fatigue. This is a diagram that sort of hopefully kind of ties it all together. So there is the first circle where it talks about primary traumatic stress. Those are more of the wound healers. These are maybe we have some personal injury, or maybe what's going on with your patient is something that's going on with someone close to you. There's a secondary vicarious where maybe you're really being empathic for your patient and you really want to help them, but you're feeling very helpless, frustrated. And then the third is this notion of countertransference, and that's where for some reason there's connections with patients. We can't always describe them. Maybe they're the same age, they have the same profession, maybe the same interests, maybe you grew up in the same town. I mean, there's lots of reasons why sometimes we bond, or we sort of feel like we're closer to some patients than others. And this as well, sometimes we get wrapped up in those feelings of compassion fatigue with these particular patients. And so you can see that it sort of fits in the middle. It's a combination of many of these factors that add to compassion fatigue. But the message is that it in itself is not equivalent to burnout, and there are things that we can do to improve compassion fatigue and things that you can do to help yourself. But if you don't do anything with it and you just let it sit there, then it can turn over time into what we call actual burnout. And there is no fix for burnout. Often it's a career change is the fix for burnout. So to kind of give you, a description of burnout, it's something that's more gradual. It has a negative self-concept, negative attitude towards work, people at work, life itself. And interesting, there was a study that was done by Maslich and Jackson, which actually looked in particular at physicians and registered nurses. And the report of actual job burnout was quite high. About 1/3 of the physicians and registered nurses reported high emotional exhaustion, depersonalization, and feelings of low personal accomplishments associated with their work. And the cartoon, I apologize, it didn't come up as big as I want, but the doctor's asking Mrs. Jones what he can do for her today, and she says that she feels as bad as he looks. So what is that? What is our path to burnout? What does kind of burnout look like? In contrast to compassion fatigue, it's those feelings of being in a rut, where your work lacks variety and challenge. You really lack enthusiasm. It's frustration, it's unhappiness and discontent, but it's more than just patient care. It's feelings of you're very discontent with the system. You're very discontent with the actual job. You kind of just show up. It's what I think we've called it, where you show up and you just go through the motions, but you don't really do the job, and you don't function at your highest level. That's more indicative of burnout versus this compassion fatigue. So I want to give this case example, and then we're going to talk a little bit about what some of the risk factors are that may influence this and what we can do about it. So Mr. C is a 66-year-old man with diabetes and HIV, hospitalized for recurrent pneumonia and foot ulcers. You've known him for the last 5 years. His hospitalization is complicated by significant foot pain, infection, and respiratory distress. His partner insists on maximal support, telling you not to give up hope on him. He trusts that you will make him better. Unfortunately, your patient continues to decline, needing mechanical ventilation in addition to multiple medications. At this point, you're feeling frustrated and helpless. You've given as many interventions as you can, and unfortunately, he continues to decline. His partner calls you pretty much daily to talk about Mr. C, what your plans are, what they can do from here. You find yourself avoiding the patient and partner because you feel as if you've let them down and can no longer face them without feelings of guilt. And then your patient dies about 2 weeks later in spite of maximal support. In that case itself, there were several risk factors that may influence care, and I just want to kind of to outline them there. So these are some of these counter-transference things that I was just talking about, but it's more of, in these cases where maybe you've identified with the patient, maybe you yourself have depression or substance abuse or some type of psychiatric illness that makes it difficult for you internally. Maybe you've known your patient for many, many years. Conflicting personal obligations. Those are things. An example of that would be in the academic world. You're a researcher and you're a clinician. You want to do more research. You're being told you need to do more clinical work. It becomes kind of this push and shove and this tugging of your time and your professional obligations can sometimes really influence care that you give. If there's an uncertainty about the prognosis or maybe some ambiguity often. And I think we see that a lot in chronic illnesses because there is a lot of uncertainty in the prognosis of our patients. In addition, there's clinical factors. Maybe your patient's been in the hospital a lot. Maybe they've had, maybe the family has dysfunctional relations. Maybe they're not good at communicating with you and the staff. All of these contribute to how we as providers sometimes deal with our patients and their families, and all contributes as a whole to how we feel about the care that we've delivered to our patients. Some of the behaviors that we might find in ourselves and warning signs that this is happening are things like we start avoiding patients and family. We no longer take their phone calls. We don't call them back in a timely manner. Maybe we have more frequent contact because we bring them back more often than maybe we should or would in other circumstances. Maybe we feel some anger at the patient or family, or maybe imposed upon. Sense of failure. Maybe, you're feeling victimized by the practice of medicine. Maybe sometimes you're just like, you can't take this one more day. You feel like you've been giving to everybody and you're not getting back. Those types of feelings. I think those are all very normal feelings, but certainly, to be aware of them and kind of examine them really helps in how we deliver our patient care and can help prevent burnout and compassion fatigue. So what happens when we don't do that, though? What happens if this continually happens with your patients and we don't pay attention to it, we don't examine it, and we don't explore it? Well, I think, it's bad for patients and their patients' family. They have a mistrust of health system and medical profession when people don't follow up with them. They don't keep them in the loop. There's certainly a lack of clarity for both the providers and the patients. They don't know where their care is going. They don't know what direction, what to expect next. There's a lot of loneliness because people don't really want to burden other people with what they're thinking and feeling. And I think there's lots of reasons for that. Where everybody's busy. You're worried that maybe no one else feels that way, although I suspect that it's probably more common than we think. And certainly, your family, you don't want to burden your family because they get tired of listening to all of your work-related issues as well. So you sort of feel like, you're all alone out there. And by continuing to avoid these issues, then, it leads to more complications overall. And so how do we address these issues, and how do we monitor ourselves, and how can we reflect on that? Well, I think, there's several things and several ways that you can go for this. I think that we can look back and recognize what risk factors we have, and reflection on the situation, and what was I feeling during that, and kind of putting a name to that emotion. Was it that I was attached to my patient, or maybe was it something about them, or was it because I really wanted them to do this and they didn't want to do that, or they wanted to do this and I didn't want them to. I think it's really important that you go back and kind of think on, especially on these patients where it's been a tough case. Maybe you've had a lot of contact, it's been a rough road, they've been visiting you a lot, to kind of go back and reflect on all of those things. Find yourself someone to talk to, some professional colleague, maybe a group of colleagues where you can bounce these types of ideas off of each other, spend some time talking about them, somebody that you're safe and comfortable with, just to kind of rehash this and say, okay, was there anything maybe that we could do differently, something maybe I could do better, what do you do? Just being willing to talk about it. Setting clear professional boundaries. I think some people are very good at setting boundaries and others aren't as good at that. But I think it is keeping for your own self-care, setting those boundaries, and when you're not at work, not having patients call you on your personal cell phone or your personal phone, those types of things, really setting those boundaries so that the time that you're away from work, you're on your own time, you're doing those things. Making sure you're talking with your colleagues. Try to have a life outside of work. When you're talking to yourself and reflecting all of this, focus on what you did well. What was it what was successful in this interaction, or what was successful in this case? And learn from those. Learn what you did well, learn what you could do better, and so that the next time, and there will be a next time, that this case comes up, you can approach it maybe from a different approach. Personally, I've practiced that by learning from some cases that I've had that have been particularly difficult, and on that reflection. And so the next time that I saw a similar case, I tried not to make the same mistakes twice. And I found that to be very useful, and I feel like if that works for me as a coping strategy, and to continue to learn and improve as we go along. And then, of course, there's all these other self-awareness things, mindfulness. Some people like to write, so it's reflective writing. It's finding whatever that strategy is that works for you. Some people like physical exercise for hours and hours at a time. That's good too. Whatever works.